Welcome back, everyone. What a great first half of the program. I'm Christina Silcox. I'm the Research Director for Digital Health at the Duke Margolis Center for Health Policy. And we are going to now be building off the last couple sessions that covered a shared systematic framework for incorporating population benefits into regulatory and reimbursement processes. So in this session, we're going to be diving deeper into the policy reforms focused on enhancing development, regulatory review, adoption of diagnostics, vaccines, and therapeutics. So what do we mean by that? Exactly what was talked about in the last two sessions, particularly that first session, that the existence of a product does not mean access to a product, which does not mean a product delivered. And even when a product is delivered, product delivered to some does not mean a product delivered to all. So when we think about approval, coverage, reimbursement, and guidance for utilizing products targeting respiratory disease, it has traditionally revolved around incentives to prevent or reduce the severity of individual infections, so individual benefit. However, many products on the market have shown important population-level benefits to reduce transmission, and stakeholders can build on that precedent for regulatory and reimbursement policies to reflect these benefits. Past policy actions provide a foundation for actionable steps to account more systematically for the transmission reduction potential of current and next generation products with the potential to actually block transmission. We will now, I want to welcome our panel on the stage. The first up is Danielle Shelfo, who is Vice President of Market Access and Health Policy at ClearNote Health. We also have Lee Fleischer, the former Chief Medical Officer and Director of the Center for Clinical Standards and Quality at the Centers for Medicaid and Medicare Services, now an emeritus professor at the University of Pennsylvania School of Medicine, and also a visiting fellow at Duke Margolis. We also have Colleen Glassmeyer, the Head of Legal and Regulatory Affairs and Patient Safety at Roche Diagnostics. And we have Haider Andazola, the Senior Associate of Healthcare and Federal Government Strategy Groups at Foley Hoag LLP. Now we're going to turn to our speakers for their opening remarks, starting with Danielle.
Thank you so much, Christina. It's a pleasure to be here with everyone today. I wanted to begin with sharing a story. I was working with Hologic when the pandemic hit in January. And rest assured, when we are motivated and need to get something done here in the US, I've got to say, with many of my colleagues in industry, we did get 4 tests cleared within 8 weeks by 4 manufacturers, Hologic, Quest, LabCorp, and the other was Thermo Fisher. That was the weekend of, I think it was March 9th. Some folks got theirs on Friday, Saturday, and then Sunday. And then within that 8 weeks as well, too, we worked as an industry with the AMA to quickly get a CPT code. And then we worked locally, because the paths were a little bit quicker, with a Palmetto MolDX program to establish an initial rate of reimbursement for the COVID vaccine, which CMS quickly stepped in because that rate was not appropriate for the need. Furthermore, working with the industry and ACLA, in the CARES Act, we actually even indicated what reimbursement would then be for a COVID vaccine. So this all happened, of course, very quickly. But I guess, the point of that is establishing a code, identifying a service, and then assigning a reimbursement rate. There are paths that exist for that. Really what the challenge is coverage. We tend to use the term reimbursement when in actuality, it's coverage. So let me share what's happened since then. As we know, the public health emergency ended on May 11th of 2023. Now, whilst Medicare may still cover and reimburse with zero copays, some of our largest payers in the country either A, no longer cover over-the-counter tests, or B, now apply copays, coinsurance, and deductibles to this once the pandemic ended. So and we haven't even, covered some other areas here, which honestly, there are different motivators by different payers. So Medicare will cover something that is medically necessary and guides a treatment decision. And that applies actually beyond Medicare to also Medicaid, VA, DOD. Commercial insurers, though, however, look for the right test for the right patient at the right time and at the right cost. So the motivators are going to be very different for commercial payers. And when we think about the issues and barriers, they're different for a Medicare population than they are for commercial, than they are for the uninsured and the underinsured. And one of my colleagues here from San Diego was mentioning earlier, who works at the Federally Qualified Health Center. I've been in those health centers. When I worked in managed care, we would go in and we would do site visits. And the dynamics that are happening with our uninsured or underinsured and that patient population, it's very different than what's happening in the commercial and in the government setting, Medicare, if you will. So it's important, we have to really kind of segment by payer to talk about how are we going to address some of the issues with regards to patient access. As we kind of thought about some of our earlier sessions, I thought it was interesting, the health forecasting component, and how can we get, truly it's more commercial payers than Medicare and Medicaid to really expand access, if you will, to testing. And there are certain things and measures currently that exist in the commercial payer setting. There are HEDIS measures, there are STAR measures, and under CMS, there are even quality assurance performance indicators. So there are current measures that exist, and then when providers report on them, create report cards for insurances and payers. One of the things that CMS can also do is CMS actually puts out bids for folks in the commercial payer business that want to provide a managed Medicare or a managed Medicaid plan. And often you submit your bid if you're one of these commercial plans in a certain region. You have to meet a number of different requirements, access requirements for primary care providers and for specialists as well. But one of the requirements for actually participating in managed Medicare and in managed Medicaid could at some point maybe even be a component that is tied to public health and reporting on these measures. Now, folks, I appreciate that may seem a bit maybe even outside of the regular framework or pathways, but when I was in managed care, we often offered expanded benefits to Medicare beneficiaries and to Medicaid beneficiaries in order to drive enrollment. So it is something that currently exists as a pathway today. The last thing I did want to talk about, though, is employers, because we often talk about, well, this isn't covered and this isn't reimbursed. Typically, it is paid at a certain amount. One can debate whether that amount is appropriate or not, but coverage is usually the issue. And from a commercial payer's perspective, there are prior authorizations. Are you a participating provider? There are a number of hurdles that you have to get through in order to actually get that payment and get coverage. But employers can offer free tests within their worksite. And so that could be another employment benefit that we could get to drive help or to drive patient access. Because one of our biggest challenges right now is, as a society, we pay more in deductibles, copay, and coinsurance than I think I can remember in my lifetime. So how do we actually, if we're going to drive access, we've got to remove some of those barriers to copay, deductible, and coinsurance. And last but not least, I'll kind of wrap up by saying, when we talk about evidence, payers have specific evidentiary criteria to cover new technology. So let's say we have a new issue, and maybe it's not COVID, maybe it's something that looks a little bit more like Zika, right? When the federal government declares a public health emergency, then payers have to cover something. But if it's not declared a public health emergency, then individually, the industry is working payer by payer to get coverage. So it would be, I think, helpful if the government, whether it be CDC, NIH, BARDA, VA, when other entities work on actually developing and publishing evidence, that can be very helpful, because from an industry perspective, especially right now, running clinical studies is extremely, extremely expensive. And the patient population that you often need, whether it's to get an FDA approval or to get covered by a payer, is quite high. The company I'm working for right now, we have to do a study in 15,000 patients and in a diabetic patient population. And I think Dr. Lipsitch mentioned before, working with other countries like Israel, we've looked into that as well too, because it's much faster to accrue and studies are much more affordable. But often those aren't necessarily the studies that payers will accept for coverage. So there's that challenge as well. But in closing, guidelines tend to drive coverage. Updating guidelines can quickly drive coverage in the commercial setting. The Affordable Care Act identifies our essential health benefits, and that really outlines cost share. So if we want to change what is covered under zero cost share, we expand our essential health benefits either under USPSTF and/or HRSA.
Thank you so much. And Lee?
Yeah, no, that's great, and thank you. You've covered some of the stuff about Medicare. But I think it's really important, and I really thank Duke Margolis, because when I was in the agency and had the position of both CMO and overseeing the national coverage decisions, a lot of these were very relevant. And in fact, some of the most important issues, I think, were highlighted not with COVID, because COVID was solved by statutory changes. Yeah. It was really by MPOX. And the daily phone calls that we had with ASPR and throughout all of HHS to try to figure out what we were allowed to cover. So there's a couple things that I think are important. The issue of authorities, and I think here at Duke Margolis, you've outlined many of those. One of the interesting things on the testing side was actually CLIA, and trying to figure out, if it's over the counter, you're allowed to do it at home. The complicating thing was they actually used a model to be able to pay for the COVID at home tests. So would that be used again? Could that be used again? As opposed to the fact that that helped really distribute all those tests, and then of course the commercial side followed. But it became really complicated about, can schools do testing? Because if they're delivering a diagnosis, then you actually have to get a CLIA, certificate of waiver. And we extended and tried to say, you didn't need it. You could have your university, or even for some states, we said the entire state could be covered by the chief medical officer or the surgeon general of the state. But other states didn't allow it and actually said it had to be a certain level of training. So I think we have to think a lot about CLIA as we're developing more certificate of waiver type tests, and as we're thinking that it's not just going to be at the doctor's office or the Minute Clinic, but it could be, at the mall, not under healthcare. We also need to think a lot about one of the learnings, and I'll come back to testing, was in vaccination, and I heard today that FQHCs would just give out the tests and order them. Well, the biggest problem we had in trying to figure out how to address the public health emergency in the beginning and getting to the most vulnerable patients is we didn't know where they were. In fact, because of the mass vaccinations, people did not bill Medicare and Medicaid. And therefore, we couldn't link it to claims and say, we've got a hot spot over here in East Baltimore that we need to go door by door and actually vaccinate those individuals. And CMS created a code. The other thing that I thought was really interesting, that I still remember the discussion with the administrator and this Center for Medicare team, was coming up with this idea of getting the test back quicker, you got extra payment. So how do we think about using that when we go forward to say timely testing results is really important because it took quite a while. And you nicely outlined the issue of the PHE. That became so important. So besides the CARES Act and the statutory changes, when MPOX came along, there were lots of discussions about the value of a national PHE, a Secretary of Health declared PHE, which type of PHE, gave which authorities both to CMS and FDA to do those tests. And with lab-developed tests, particularly with the recent FDA statement where they put out the reg to potentially regulate that, what do we really need? Do we need like 5 tests sent to the CDC to say it's good enough to be an accurate diagnosis? How could we suspend it? So I think all of these are important. I did want to say there was a lot of talk about qualities. You know, CMS does not use, and I can attest, and so can I'm sure Mark, does not use money and can never use qualities in reviewing our programs, or certainly we currently don't. CMS currently doesn't, but importantly, the costs enter in whether or not you open a national coverage decision, as well as the public health emergency. So what did I learn during MPOX as much as COVID? Because I said COVID was easier. The authorities were there. Was, you know, the payment issues and the reasonable and necessary requirements, and particularly ACIP versus the U.S. Preventative Task Force. That trying to get a USPF endorsement is not easy. In fact, I would say it's extremely hard. So how do we get to that absence of cost sharing? How do we get to the ACIP, whether ACIP alone, which can affect depending on the statute, the answer? Trying to get the answer in Medicaid is nearly impossible in that every state, excuse me, is different. And that became a real challenge and took days and days of phone calls. The issue of screening because of the statutory authorities, whether or not, so for MPOX, could you just screen anyone who's at risk, or did they have to have an exposure and a documented exposure that met the statutory requirements whereby you could actually pay for it and pay for it without cost sharing? So again, those are important. And vaccinations, of course, you know, the Part D with the ACIP recommendations, as you mentioned, but also the fee-for-service. Lastly, I think, and again, thank you so much to Duke Margolis for what happened while I was still in the agency, and I still remember, I think it was my third to last day, if I remember, in your conference room having a discussion about the authorities to actually get reporting. So the question really is, as was mentioned previously, it's CMS authorities which got the data to the CDC of where the events were occurring, particularly in the hospital setting, as opposed to the state agencies. And I think was mentioned earlier today, the way the country is constructed, it really goes to the state and doesn't go to the federal government, this information. And because of the way the states are really responsible and the public health agencies to addressing it locally, what do we need to think about from an authority using LOINC codes and others? I know that the large testing groups are thinking about this, but what can we do to collect this data so that we can actually address it quickly? Thanks.
Thank you. And Colleen?
Thanks, Christina. It's great to be here with everybody. I'm so happy to have the opportunity to share the stage with all of you. And Mark, thank you so much for the invitation. It's hard to believe it's been 20 years since I first worked for you, but here we are. I'm going to switch gears for us a little bit and frame up the part of the discussion that deals with the extent of FDA's statutory authority to do some of the things that we've all been talking about. And I will keep it as sort of lay-friendly as possible and not delve too much into the weeds of the statutory and regulatory provisions. So point one is, there are some laws that tell FDA what it can and must do and what it may not do in respect of granting licensure for therapeutic products. And that includes, for purposes of this discussion, vaccines. And then there's separate provisions that prevail in the device context, including for diagnostics. And although it's sort of generally understood that individual benefit is the touchstone for those clinical benefit assessments, in fact, the legislation itself and the regulations themselves aren't so limited. So if you take drugs as the paradigmatic example, and vaccines, in addition to therapeutic drugs, would be subject to this provision under the Federal Food, Drug, and Cosmetic Act. The law doesn't say that development has to be driven by considerations of individual patient benefit. It just doesn't say that. It says that drug effect has to be measured according to a baseline that's defined as what the manufacturer claims in its labeling. So in the first instance, the manufacturer determines the bogey, sort of, okay, what is the clinical benefit target against which we are engaging in these development activities. So just to illustrate, the licensure standard and the rules speaks of evidence from adequate and well-controlled trials that a drug product will have the effect it purports or is represented to have under the conditions of use prescribed, recommended, or suggested in its proposed labeling. No reference to individual patient, no reference to population benefits. For medical devices, there's a corresponding evidentiary standard that's even more flexible. It was later promulgated. FDA, in setting up the device program, learned some lessons from the implementation of the drug program, and accordingly included a little more play in the joints in the evidentiary standard for assessments of effect in medical devices, and it's valid scientific evidence. So, substantial evidence versus valid scientific evidence, commonly understood, and the language in the regs backs this up. Even more kind of permissive evidentiary standard, again, tailored to the claims that are made in the labeling determined by and formulated by the manufacturer, the product developer in the first instance. Another really interesting element of the statutory scheme for purposes of this discussion, since 1997, FDA has been subject to a bit of a limitation in its authority over what manufacturers can say about the benefits of their products. And I'm speaking here of so-called FDAMA 114, Section 114 of the Food and Drug Administration Modernization Act. And it says if you want to, as a manufacturer of a product, drug or device, make a claim of economic benefit associated with use of a product, you may do so, subject to an even more forgiving standard that's sort of uniquely tailored to claims of economic benefit as opposed to purely clinical benefit. And that standard is the so-called CARS standard, competent and reliable scientific evidence, CARS. And that's a standard that was lifted from FTC law, garden variety advertising law. And it's intended to be extremely friendly and enabling of economic benefit claims. If you start to think about the line between a clinical claim and an economic claim, it starts to get a little challenging. So for instance, if you take it out of the infectious disease setting and think about like an injectable antipsychotic, it's just intuitive that if you deliver an injectable antipsychotic medicine on a weekly basis as opposed to requiring a patient to adhere to a daily solid oral dosage form schedule, that you would realize some economic benefit because by lengthening the interval between doses, maybe you reduce the need for supervision for a patient who's maybe got uncontrolled symptoms. That just seems intuitively satisfying. And it's a benefit that is economically relevant in addition to being clinically relevant. FDA would say, well, reduction in hospitalization in that population, for example, is both a clinical benefit and an economic benefit vis-a-vis payers. So it starts to get a little challenging to find a bright line in between clinical and economic benefit claims, but it's something that the statute provides for. So there is this framework. You have this taxonomy of evidentiary standards. none of which limits FDA to considerations that are just really focused on individual patient benefit. So that's point one. Point two is there is, and Christina, both you and Mark made this point, there is precedent for FDA to think at a higher level about population benefits. We see it in opioids. So if you would like to make a claim about abuse, resistance, or deterrence, there's a role for EPI to play in establishing that benefit. That is more on the risk side than the benefit side, but there is some facility within FDA around those kinds of higher level benefit claims. Another way that FDA thinks about population benefit versus individual is if you think about the traditional clinical trial design model, what you're doing is you're accruing patients. Increasingly, the expectation is this will be a representative assortment of clinical trial subjects. FDA looks at data generated in those subjects and then draws a conclusion about whether the drug will be effective across the entire intended patient population by extrapolating from the data derived in those specific patients. That's why we have policies that are geared towards assuring inclusion of women in clinical trials, for example. It's why we have special standards for the inclusion of geriatric subjects and standards governing how we extrapolate from data in hand to efficacy in pediatric populations. It's why we have special standards for patients with kidney impairment, for example. Those are all examples of how the agency makes judgments about effect in a population that may or may not perfectly correspond to the population in which individual benefit was identified. So there's a lot of judgment and inference and interpolation, extrapolation that already occurs under the existing paradigm, and one hopes that could be leveraged in service of accomplishing some of the important infectious disease-related policy objectives that we're talking about. The last thing I want to say, although I have lots I could add, is that I am vexed by the lack of good options to treat pediatric cough and cold. And I think about the full armamentarium, and you think about the effect that the dearth of drugs in that category will continue to have on real people. You've got, households where one coughing child can keep everybody awake, interfere with people's productivity, their ability to just stay sane. And I think if we're talking about drug development incentives, we have to talk about pediatric cough and cold products. That's the symptom. We've got still rampant overdose among kids who are coughing, continued discussion around whether it even makes sense to use antitussives. And just in the last few years, FDA asserting that, and I agree with this recommendation, over-the-counter cough and cold drugs should not be used in kids because of risks and the lack of adequate evidence of effect. And even honey, which is just as good as a lot of other things, isn't recommended for kids under 1. And then it was only in 2018 that FDA emphatically recommended against the use of prescription opioid-based cough and cold drugs in kids. So as we think about access issues in respiratory virus season, just want to put a plug in for thinking about incentives for drug development in pediatrics and cough and cold. That's the relevant over-the-counter drug monograph in particular.
Hi, everybody.
Well, thank you everyone for having me be part of this panel. And I have to echo Colleen's feeling about cough and cold medicine for children. As a father to an infant daughter, every time she gets sick, we know that there's just going to be a month-long cycle of everyone getting sick one after the other. So definitely can echo that sentiment. I think where I would maybe not shift gears entirely, but just because my expertise is coverage and reimbursement, speak a little bit to the coverage and payment side of trying to incentivize innovation in this area where the primary goal is a public health goal of reducing infection transmission. And I think to Danielle's point, you really have to segment it by payer, and you probably have to start with coverage, because you can have coverage without payment, but you can't have payment without coverage. And in the case of different payer coverage policies for these types of therapies, I think the main issue is just having some type of standardized evidentiary framework to be able to assess the risks versus benefits for these products. And I think that probably the FDA is in the best position to do that. And it sounds like they have the authority to do that. They just need to actually do it. But once you have that standardized framework, I think you start looking at what are the possible leverage points out there to be able to not necessarily mandate coverage, but really spur coverage at a much broader level. And I think the white paper that Duke had released earlier on this topic, identifying, and as Lee spoke to earlier, ACIP and USPSTF are not regulatory bodies, but are organizations that are well poised with an affirmative recommendation to really ensure broad access to these types of products, and not even just setting aside at reduced cost sharing, right? But just the fact that because those recommendations are a preventative benefit under federal law, it trickles down to, qualified health plans on the exchanges, Medicare, Medicaid, and then you add these other programs like the Vaccines for Children program as well, that program primarily is governed by what ACIP recommends, right? And ACIP doesn't really have any regulatory guidelines in terms of what it can and cannot recommend. And I think we've seen them open up in terms of the types of recommendations and types of factors that they have considered in recent recommendations, where they've looked at technologies that have probably not been in sort of the common understanding traditional vaccines in the way that traditional vaccines work, but they've incorporated those types of technologies into the recommendations, like with RSV and such. And so those are real, I think those non-governmental bodies that still have a lot of sway when they make a decision because of the confidence that has been placed on them by Congress through different legislative enactments, those are real potential leverage points to be able to expand coverage to these technologies, whether they be, mostly I'm thinking about therapeutics. And then once you get coverage, I think you have to start thinking about reimbursement, and the most straightforward solution is just reimburse differently for them. And I think you can have some differential reimbursement, but again, it really depends on what payer we're talking about. I think in Medicare, you're sort of limited in some cases if this hypothetical product is administered in the outpatient setting. If it's in the hospital outpatient setting, maybe Medicare can increase reimbursement for it, although we've seen differential reimbursement be struck down by the Supreme Court in the case of 340B drugs. And that was different, obviously, but the statutory authority that CMS had relied to adopt differential reimbursement for these specified covered outpatient drugs only really seems to give you leeway to shift reimbursement in cases where you're treating hospitals or providers differently, and not necessarily, we think that this product here specifically has great rates of reducing infection transmission, and so we want to pay for it higher. The statute doesn't necessarily support that kind of differential reimbursement, but there is some authority to think creatively about how to differ reimbursement between different providers in the outpatient setting. The physician office is a bit more challenging just because the reimbursement methodology for drugs, which presumably these hypothetical products would qualify as drugs, that is really codified in statute, and it's maybe there are creative ways to think outside the box in terms of how to differ reimbursement in that context, but you are a little bit more limited there. And then Part D, right, which I think we would ideally want most of these products to just be self-administered by the patient. In there, CMS is a lot more limited in terms of what it can do, just given the non-interference clause and the notion that CMS is not supposed to interfere with negotiations between payers, pharmacies, and manufacturers. But even there, I think as Danielle pointed out, you have star ratings, you have other different types of mechanisms that you might be able to leverage to incentivize the financial reward for using and expanding access to these types of products. And I just want to close because I know we're running short on time. I think one thing that I am still not really sure how to address is how to modify behavior of the consumer and how to get them to take these products knowing that the benefit is not intended to fully accrue to them, but to the people around them. And we've already seen those challenges spring up with the COVID-19 pandemic and with the reduction in the vaccination rates now that sort of the pandemic has officially ended in terms of a public health emergency. But even there, I think there are potentially creative ways, especially around contracting and what you might allow manufacturers to do. I think one thing that I was kicking around and thinking about this topic was, what if you create a safe harbor, right? OIG has broad authority to create safe harbor. What if you create a transmission reduction focused safe harbor that allows manufacturers to actually generate volume in a protected way and go out and market, incentivize consumers to use this product? I don't know, you get like a $15 gift card or something like that. Of course, the economics behind that is a separate question. But I think OIG could probably exercise its safe harbor authority a little bit more liberally and try to see creative ways to maybe just leave it up to the private parties to figure out how to do this in a compliant way and just give them enough flexibility to be able to determine how best to do that within these defined parameters that the OIG, presumably in consultation with the FDA and CMS, could come up with to try to push that type of contract innovation in a way that tries a bit better to address this behavior modification among consumers, and which to me I think is like the main sticking point on this topic.
So this has been really interesting discussion. I'm going to remind everyone that we do have the Slido for the in-person participants and for the online participants to ask questions. You can either scan the little QR code or you can go to slido.com and in the blue box put #transmission. So I have heard a lot of fabulous things from this panel. So we started out with Danielle, who talked about the difference between coverage and reimbursement, and really the different payers, meaning have different standards, and they may need different incentives. And Hyder picked up on this as well, so did Lee, which I think is really important, and one of the, I think something that needs to be understood to be able to make these effective. You're not going to be able to make maybe a one-size-fits-all policy. At the same time, I'd like to throw out that something that Hyder said at the end, which is how do we help people modify behaviors? And when everybody has a different standard, when people go to the doctor and can't be told by their neighbors what to expect, their friends and neighbors what to expect when they go, what are they going to have to pay, things like that, then I think it's really hard to modify behaviors.
Everybody has different insurance.
Everybody has different
Everybody
insurance.
has different
and then if
co-pays.
everyone has a different kind of
Yes.
set of what's going to happen, I think it's
Yeah.
really different.
But
So
it's not just about, if I might,
yes, please.
it's not just about that coverage. I mean, when the vaccine came out and we saw the wide variability in the uptake and the final decision, and I still remember briefing up that it was time to mandate that all healthcare providers using the COPs take the vaccine. That was the only thing that changed behavior. And we had tried everything. And one of the interesting things I found, and this gets back to your comment, is we were about to put out a program that we were going to call the Healthcare Heroes if the nursing home staff took the vaccine. And the behavioral economists and the organizational psychologists I talked to said, "Are you insane?" Because they said, so if you go to work and you take care of nursing home residents, but you don't get the vaccine, you're not a hero. So we actually called it community champions. So I think we need to learn from the pandemic that we need to reframe that this is about the community, but we haven't succeeded.
Yeah. And vaccines do change also what cost effectiveness will look like. I've heard several folks talk about, it would be cost effective. We can't assume that it would be cost effective. we really actually shouldn't assume that it's cost effective. Because when you look at the incidence and prevalence of the patient population that get, COVID, that get flu A, flu B, and if you divide that by the number of patients that actually end up in the hospital with something that is very expensive from a payer standpoint, that might not net out to be cost effective. But one of the biggest things that I feel like I took away from the pandemic, and I was honored to be able to hear Debbie Burke speak. She talked about how we kept kids out of schools for a couple of years if you're in a public school system. And we talked a little bit about evidence. And one of the biggest issues from the pandemic was the impact on mental health from lack of socialization. And if we go back to just basic blue zone behaviors from Dan Buettner, and actually it's even further published by the CDC, what does the impact of lack of socialization from infectious disease, what does it have on our kids and society writ large, who already spent a couple of years actually not socializing? And so when we think about wellness as encouraging a specific behavior, do we publish on how it impacts socialization, how it impacts mental health, how that can decrease mental health claims that a payer may also pay for as well too. And many times, even in your insurance policies on the commercial side, you have limits to how many visits you can have under mental health. So how does keeping a society vaccinated, really encouraging work from home? I don't know about folks here, but I know several employers that right now are really encouraging folks to come back to the office. And in fact, I've even heard, mandating 4 or 5 days. And so there's a little bit of a boomerang effect now from from employees being outside of the workforce. So I do think evidence can drive behaviors. Guidelines, certainly, if the societies, we don't actually have physicians from any of the societies.
I wrote lots of guidelines,
Wait,
but not
okay.
from the infectious disease space, but yeah.
For infectious disease, if it is in guidelines that a patient should be tested XYZ, then commercial payers follow guidelines. They might associate a copay with it, but they will follow guidelines. So from an access and standpoint, or an access and coverage standpoint, guidelines are one of the best ways to address that.
So, sorry.
Oh, no, I was just going to say from an evidence standpoint, I don't necessarily think I would hang my hat on cost effectiveness studies coming out positive, because with the number of tests we're talking about and hospitalizations today, I just don't know.
And I think this came up in a couple of the different in the previous sessions as well, right? And Blythe talked a little bit about the marriage of health economics with infectious disease modeling and trying to understand that to try and help. And I think it came up with some of the people in the session too. Risk modeling and changing behavior based on what is actually happening on the ground. And I think that this might be a great space to go to an audience question. Which is, how do we think about incentivizing innovation in drug development while dismantling or not encouraging, while not dismantling and not discouraging the blending of economic and clinical claims? Is this possible or is this favorable? And I think this goes to something what you just said, which is that there are economic claims that are actually tied in with health claims. And so as you have economic challenges, individuals have economic challenges, that also adds stress and causes health challenges as well.
Yeah.
So I think that, but I can also see that concern around combining those two things, and Lee made the point that CMS does not consider some of those issues when they're making decisions. So I'd love to hear from all of you. Maybe we'll start with Colleen, since the audience directed it towards you, but I'd love to hear from all of you on this question.
I'm not totally sure I understand the question, but I'll answer the question that I would like to have been asked, perhaps. I think that the reason that Congress enacted FNAMA 114 was to push FDA away from past behaviors that arguably disincented drug development that considered economic variables. So the key thing about these variable evidentiary standards in this context is, for a clinical claim, the default position is you have to get FDA to adjudicate it before you can make it. So you can't, under US law, you can't, for the most part, you can't just bust out with some clinical benefit claim and marketing your product without first getting FDA to sign off on that claim. With an economic claim, you can, even if it has some clinical, implication. So that represents sort of a desire on Congress's part to facilitate the dissemination of economic information about uses of different products, because the expense in drug development is from evidence development, which is tailored to satisfy FDA's sort of voracious appetite for data, which a lot of us share. So that's how the system is meant to work. I'm not sure that's totally responsive to the question, but there's at least a little bit of music behind the way the legislation was written.
Oh, I think that makes sense. Lee, did you want to add on to that?
Well, I think you made one point that I keep thinking about, and I know Peter's on next, which is that the FDA is required to look at the indication brought before it in the population. That I think you made that claim. And CMS is reasonable and necessary for a clinical benefit. So the goal that we had over the last 3 years, and talking with Peter and his colleagues across the agency, was making sure that the evidence aligned to both, and making sure the surrogate, whatever that outcome, could meet both standards. So I think that's really the key thing to incent innovation, is make sure that the FDA and CMS send definitions of a good outcome that could force both coverage, approval and coverage, were aligned.
Yeah, I think that makes sense. Did anyone want to add anything to that?
Well, I would just offer, if we took a poll of most manufacturers for tests, you would be hard-pressed to find any that would want FDA to regulate on clinical utility and cost effectiveness. When you go through the FDA, they are opining safety and efficacy on your analytical validity and your clinical validity. So really, the time that it takes to do that, especially if you're talking about accruing 10,000 patients, it would take you an additional several years just to get cost effectiveness data as well too. So I don't know that from an industry perspective, that's the way that industry would align. It doesn't necessarily, and industries actually can be pretty effective at working with HEOR experts to develop clinical utility and cost effectiveness. But I would just challenge us that, if we run the numbers on models, and it all depends on what you measure, right? It might not necessarily be cost effective. It could be cost neutral, or it could be cost additive. If it's cost additive, commercial payers will cover it, but you also have to have outcome studies. If you're going to add to healthcare costs, they want to see that there are net health outcome benefits to that.
Yeah.
I know we're over time, but I just want to put a fine point on
We actually have an extra 5 minutes.
Oh, good. One quick thing. So I think it will be useful to this conversation to define a corridor within which FDA does not need new data to substantiate a regulatory conclusion. As I said before, FDA draws inferences all the time, and FDA is, of course, not just a science-based agency, but like the premier global, science-based agency. I actually think FDA is more accurately described as a judgment-based agency, because the data are what they are, but figuring out what to do, what's actionable about those data, is the art of what FDA does. And there are lots of scenarios in which FDA reaches conclusions without consuming or requiring the generation of new data. Nobody doubts that the proliferation of statin use in the United States yielded a population benefit. You talk to folks in the cardiovascular program at FDA, I think they would still be saying what Bob Temple has been saying for 50 years, which is like if everybody could be prescribed a statin the minute they hit 45, the world would be, the country would be better off for it. And it's interesting to think about that in the context of GLP-1s, et cetera. So I just think that there's a lot of room in this conversation to talk about places where FDA can say that's self-evident. That's undoubtedly true. We know that that's real, even though we don't have a sponsor coughing up 47,000 patient years worth of data to tell us it's true in the way that we do in traditional drug development. Yeah. So that, I think, which is partly, I think, a corollary observation. I mean, we're not going to require diagnostic manufacturers to generate what in the industry we often refer to as clinical utility data, because there's clinical utility and clinical utility. You can reach a conclusion that something's good at the population level without requiring the generation of new data, shoving it in your face that it's good in the way that we do under traditional regulatory standards.
But I think that there are cases where we do need additional regulation evidence to be able to show that there is transmission reduction, right? I think diagnostics is kind of a special case in some ways because you can show, well, now that you have knowledge, you can take steps. But that's obviously then dependent on people actually taking those next steps. I think we had a thought experiment in the last session where what if there was a pill you could take and you would still be sick, but you wouldn't be infectious. And I'm thinking through, what kind of infrastructure would we need to have in place to actually show that? And would love to hear a little bit of y'all's thoughts on how we can, what's missing right now in the healthcare and public health infrastructure that would help us be able to make those sort of transmission reducing claims.
Yeah, I would agree on reporting. I think, Lee, you mentioned earlier, LOINC reporting, and we don't really have the infrastructure. We could probably pull data, and I believe it may have even been done so during COVID, pull data directly from the machines, at least when they're run from, a physician's, a clinician's office, assuming that they're using like Cobas machines or Panther machines, et cetera. And that potentially could feed right into a specific database. But really, we rely on claims. We rely on claims data, whether it's, and you can mine the CMS claims data, you can mine, even United has one of the biggest healthcare data repositories, IBM Truven. There's ways to mine that, but we really usually rely on claims to do it.
I think Dr. Zink did a phenomenal job during the public health emergency of trying to get us data. I think the real key is a way for both a federalized and a state-based data structure so that it's shared, so that we can really, with real-world evidence, which I know Duke Margolis is all about, really focusing on getting that data faster. But that's a change in the way we structure public health in this country.
Yeah.
And this sort of overlaps with the previous question from the audience, but I feel like there's, I think Colleen's point is really astute in terms of trying to better define the role that the FDA has in this conversation, and maybe not characterizing the FDA as having more of an obligation in this space than it actually does. And I say that because as we were talking, I'm sort of reminded about the many conversations I've had with CMS, because CMS doesn't, the only time that they perform these assessments, right, of risk benefit is through an NCD or through some type of regulatory mechanism that requires them to do that. And I'm specifically thinking of like NTAP and substantial clinical improvement. And oftentimes there's this question of, we'll say X product does Z, and then the response will be like, where in your FDA clinical trials does it show this? And then we oftentimes respond, and they agree with us. It's like, well, it's self-evident, or we have these other studies that you can draw an inference that this is exactly what happens. And they've been pretty receptive to that, I think. And so this conversation about, oh, well, what are the rules around health and economic data, and what can FDA do in that space? Maybe that's just putting too much of an onus on FDA, and maybe CMS today can start thinking about how to incorporate a assessment framework, using its reasonable and necessary data that is more encompassing of these types of issues around, viral transmission reduction, et cetera.
All right. Heider, I'm going to let you have the last word there because we are a little bit over time. Thank you so much to the panel. Y'all have been fabulous. I really appreciated this discussion.
Thank you.
Thank you.